This is our classmates and my gurus and his gurus, Dr. Deshpande. Man hardly learns from his success, but learns from his mistakes. This should be done. We should learn from our mistakes. Don't repeat it, otherwise it will be your failure. A mistake that makes you humble is better than an achievement that makes you arrogant. So don't afraid of mistakes. It will make you more expert. Erasers are made for those who made mistakes. Erasers are made for those who make mistakes. Erasers are made for those who are willing to correct their mistakes. Write down other thing. Write down other thing. So you can have a progress. How to keep him? Now let us observe the mistakes. How to keep the emergency medicines in room. This is my hospital's mistake. I asked my sister to give atropine 30 minutes before local anesthesia. When I reached and I took the BP, it was 250, 240 by 150 because adrenaline was given intramuscular. From that day, I started to keep both injections away. One is on anesthetic trolley, second is to the dressing trolley. Don't keep together, otherwise sister read with only A, atropine and adrenaline, they will give it. Lignocaine versus pentothal. This is second mistake. Prepare the local anesthetic drug in the morning. It was under short GI anesthesia. Pentothal was ready, diluted. Sister collected it and gave me. After 10 minutes, there was no anesthesia, local anesthesia. Then I found it. It was the short GA anesthesia. So keep it away again, local anesthesia, and otherwise sometime you will give IV lignocaine. So keep it away. Electric gadgets and spirit. ये दोनों दुश्मन है. In our times, we were used to have a spirit for painting. Your patient is lying and spirit has gone to the hairs. As soon as you start a quadri, the spirit will be fire. So don't use simultaneously. Keep 10 minutes away from the spirit. Hemorrhoid and hemorrhoid surgery. Don't do any hemorrhoid surgery without PR. Otherwise, you will miss malignancy. If you will miss malignancy, there will be some punishment to you anytime. So always do per rectal examinations deep into the rectum, particularly in the old age patients where there is a change in bowel habit. Don't go for hemorrhoid surgery immediately. Otherwise, you will be punished anytime. Second, if there are change in bowel habit, there is an increased diarrhea, think about it, it may be of inflammatory bowel disease. Don't do any hemorrhoidal surgery immediately without ruling it out. So this is the second mistake which should not be done by anybody. Because I have seen a lot of patients post-operative heavy bleeding because they have not diagnosed ulcerative proctitis, done hemorrhoidal surgery and there was profuse bleeding. Actually bleeding was not from the hemorrhoids, it was a bleeding from the ulcerative proctitis. So don't do it. Ksharsutra ligation versus other material. When I was student, I thought have a Ksharsutra ligation. Later on, I realized there is no need of Ksharsutra ligation. So there is a reference by Chakradat, not by Susrut, not by Charak. There is no Kshar in that Snuhikshir Bhavita Kshar Sutra. There is no Kshar at all. We are using Kshar Sutra with Kshar. So my personal request is don't repeat it. Because when I studied it, I changed it, I had a better result. So my personal request, don't use Kshar Sutra for ligation of the hemorrhoids or any Mansankur at the gula. Hemorrhoidectomy versus other procedures. If you will practice, you will notice that most of the other techniques have more complications and more recurrence. So, in your early life of practice, don't try it. Otherwise, your name will be very bad. So, the procedure which gives the best result, always try it. Don't do newer fashionable techniques for the hemorrhoids. I have many discussions with my juniors, colleagues, or friends. They all accept it, but they will never anyone will say this is the not a good technique. So whichever technique is your best in your hand, do it. Don't try to another techniques. Surgery for conservative. This is again question. Whether to do surgery or conservative treatment. In my early life, I was using conservative treatment. It will take 3 weeks to resolution. But as soon as I started to operate immediately, it was better result. In this type of cases where there will be very less pain during operation, there will be less bleeding during operation because all are coagulated. All vessels are blocked. So there will be very less bleeding. If you have a perfect technique to give the incision, there will be no post-operative stricture chances because you are keeping the bridge. So if you have, then do immediate surgery, patient will be very happy. Fistula surgery. Always think about the fistula when patient comes in old age. Because the fistula will be very painless, very easy, you will pass the track, you will get the internal opening. When the fistula is in the older age, chances are of malignancy. Rule out it, don't do it. Because I have diagnosed such cases that this is a case of malignancy, patient is not ready, they change after 2 years, yes, then the malignancy was very developed, they accepted, so rule out malignancy even in fistula. What is the abscess? When fistulous abscess is primary, patient is coming primarily with you, don't try to find out the fistula. This is my suggestion for new beginners. Don't do finding the fistula and fistula surgery. Always do best IND and best follow. After 7 to 14 days, during 7 to 14 days, when the healing is there, find out overgranulation tissue at one place. If you will pass the probe, you can find the track. So you will not make any misdiagnosed case or misopening at another level. So don't do it in abscess. When you are expert, then yes, you can go for it. Otherwise, don't do it. Non-mature tract. When the abscess is burst, 2 months are passing, but tract is not mature. No need of fistulectomy. Can go for fistulotomy. There will be good results. Mature tracts. If it is a mature tract, very fibrous tract is deeper in the tissue, I will suggest fistulectomy rather than the fistulotomy. Otherwise, wound collapse will be not there. There are chances of recurrence. So go for it. No internal opening found. What to do? Should we made or not? Should we do it or not? See, according to the modern science, if there is a two opening, then it is a fistula. Otherwise, it is not fistula. But if it is intersphincteric fistula, there should be only one opening. Because one opening is at the intersphincteric root, second opening is not there. So they are ready to accept it, that one opening may be a case of fistula. If you go through the park classification, everything, they are the drawings. So any tract is crossing the external sphincter and entering in the intersphincteric space, or without crossing, it is in the intersphincteric space, it is fistula. Treat as according to the fistula, there will be no recurrence. Don't treat it as a sinus, otherwise there will be recurrence. High internal opening in the rectum. This is the common question. What to do? If the high internal opening is high in the rectum and end tract is intersphincteric, without any fear, lay open it. If you have a daring, you can lay open. Otherwise, you use different techniques for lay open. There will be no no incontinence. I have taken a lecture regarding the Guda Marma. I tried to explain in that okay, what is Guda Marma, why there is no incontinence, everything. So, but if internal opening is higher and tract is transsphincteric, then one should think about it. It is a very complex fistula. Don't pass the Kshaar Sutra through that tract. There will be more infections and more abscess in supralevator space. So there will be a different technique. So this is my suggestion. This is the tract. This is an intersphincteric tract entering into the rectum above levator any. Yes, you can open it by any technique you want it. You can do it. Thank you. Thank you, everybody. I think I have completed my lecture within my